Hi, getting a perfect result after repairing a cut flexor tendon in zone 2 is the dream of many a surgeon. In fact, it is quite easy provided we understand the basics of the flexor tendon, the anatomy, the biomechanics, the tendon biology and the healing process. The next most important thing to understand is the surgical technique. Which suture to use, how many strands should be used for the repair, what is the core suturing to be done, what caliber of suture should be used, what is the type of suturing that should be done. All these will be discussed in this video to help take you closer to that dream of achieving a perfect repair in flexor tendon injury in zone 2. We shall deal with the topic of flexor tendon repair in zone 2 under the headings of a brief history, the basics of tendon repair, incisions and exposure needed, the techniques of tendon retrieval and repair techniques consisting of the core suture, the coaptation suture and the repair of the sheath and the future of tendon surgery. The history of tendon repair in zone 2 is as interesting as the repair itself. It was Sterling Bunnell who mentioned the term no man's land in the second edition of the book Surgery of the Hand in 1948. He said the primary suture of the flexor tendon between the distal crease in the palm and the middle crease of the finger is called the no man's land. This was attributed to the fibro-osseous digital canal in which both tendons interweaved in a very complex manner. The multiple pulleys increased the complexity because minimal swelling of the epitenon could impair free motion of the tendon. Hence, the margin of error in this zone is very small. The year 1960 is arbitrarily considered a benchmark year. Before 1960, three prominent surgeons of the era, Bunnell, Mason and Boyce, preferred secondary tendon grafting as compared to primary repair in the no man's land. In 1922, Bunnell said, suture the wound, wait for healing, then do a tendon grafting. After 1960, in the early years, Kleinert submitted his controversial report to the annual American Society for Surgery of the Hand meeting, in which he reported an astounding 87% good to excellent results on private service patients. This was published much later in 1967. So what had happened after 1960 to bring about this change? Advances in the understanding of flexor tendon anatomy, biomechanics, nutrition and healing was the first factor. The second factor was advances in technique. Stronger repairs, meticulous surgical techniques, rehabilitation protocols and development of skills in surgeons improved. We shall first see the basics of tendon repair in zone 2 under the topics of timing of repair, unique features in zone 2, the anesthesia required and the surgical basics. The repair can be done within 24 hours when it is called a primary repair, from 10 days to 3 weeks when it is called a delayed primary repair, and after 3 weeks when a repair can no longer be done, only a secondary reconstruction can be done. The primary repair is always the best because it has the advantage of primary healing of all the wounds, early rehabilitation and early return to work, and it avoids the muscle myostatic contraction and retraction of the tendons. However, primary repair cannot be done in all patients presenting within 24 hours. Existence of other life-threatening injuries, associated fractures which cannot be stabilized immediately, associated skin loss over the flexor system or wounds with biological contamination preclude the primary repair of the tendon. For example, in this patient with injury on the 3 fingers and injury to the flexor tendon on the ring finger, primary repair on the ring finger is not advised as the viability of the skin flap that has been raised on the ring finger is doubtful. However, if primary repair is not possible, delayed primary repair can be done after 10 days and up to 3 weeks after the wound has healed well, when the retraction of the tendon has not yet completed and the emergency can be converted to an elective procedure. But we should always remember there is a chance of a tight repair in delayed primary repair. After 3 weeks, repair of the cut tendons will not be possible due to retraction of the proximal ends. So, reconstruction with tendon grafting or tendon transfer can be done, but only after tissue homeostasis has been achieved. That is, the scars and joints become soft and supple. So, it is well established that primary repair is the ideal repair, and the criteria for ideal repair have been enunciated by Strickland. They are: first, the easy placement of sutures in the tendon, secure suture knots, a smooth juncture of the tendon ends, minimal gapping at the repair site, minimal interference with tendon vascularity, and lastly, sufficient strength throughout the healing to permit application of early motion stress to the tendon. Before we go into the search for an ideal repair, we need to understand certain unique features of injury to the flexor tendons in zone 2. There may be injury to the nerve and vessel, there may be an associated fracture, there may be situations where both the FDP and FDS are cut, situations where only the FDS is cut or only one slip of the FDS is cut, or there may be a partial cut of the FDP or FDS. We shall consider each of these situations individually. When the digital nerve and vessel are injured, the nerve needs to be repaired with 10-0 polyamide epidural sutures under microscope magnification, and if the artery is injured and needs to be revascularized, it can be anastomosed with 10-0 polyamide simple interrupted sutures again under microscope magnification. The repair of the nerve and artery needs to be done after the tendon repair has been completed. If there is an associated fracture, it must be fixed before the tendon repair is done. K-wires or plate and screws are ideal for such fixation. The commonest situation is when both the FDP and FDS are cut in zone 2. The first option is repair the FDP tendon only with debridement of the FDS stump. The second option is repair of both FDP and FDS. And the third option is repair of the FDP with repair of one slip of the FDS tendon alone. Before we analyze the three options, we need to remember that after FDP and FDS repair, the gliding resistance is increased by 247%. After FDP repair with only one slip of FDS repair, the gliding resistance is increased 132%. And after only FDP repair, the gliding resistance is increased by 103%. Keeping this in mind, we shall now consider the option of repair of FDP only. There is a risk of failure if the only repaired tendon breaks down. This can be done in late presentations and also in old infected cases. It can also be done if both the slips of the FDS tendon are to be repaired underneath the A2 pulley, which makes it a very tight compartment. The option of repair of the FDP and one slip of the FDS is also attractive since it will not cause any gliding problems. But when we consider repair of both FDS and FDP, we need to remember it has got many advantages. FDS increases the digit strength. There is improved flexion at the PIP joints. It preserves the short vincula to the FDP and improves the healing potential. It acts as a pulley for the repaired FDP, and the intact FDS prevents PIP joint hyperextension deformity. Hence, it is ideal to do repair of both the FDP and FDS. But repair of both these tendons may produce overcrowding within the sheath and compromise the result. It can be done safely when the suture lines of the FDP and the FDS do not coincide and the repair site is proximal or distal to the A2 pulley. We shall now consider the situation where only the FDS or only one slip of the FDS has been cut. It can either be repaired or it need not be repaired. The repaired FDS will definitely improve the function of the finger, but we must remember that it should not compromise the function of the uninjured FDP tendon. The next situation is that of a partial cut of the FDP or FDS. If there is more than 75% cut, it needs a full repair consisting of the core suture and coaptation suture. If there is a 25 to 75% injury, only coaptation sutures are enough to restore the continuity and prevent impingement of the cut tendon on the pulleys. And if there is an injury of just less than 25%, there is no need to do a repair as it gets rounded off with continuing movements. Considering the anesthesia under which the surgery is going to be done, local anesthesia alone is not preferred as it may not allow for the application of the tourniquet for such a long time. Regional block is preferred. In children, general anesthesia is preferred. However, There are newer techniques like the WALANT technique, wide awake local anesthesia and no tourniquet, or the wide awake hand surgery technique. By these techniques, flexor tendon repair can be done in zone 2 without the use of a tourniquet. 15 ml of 1% lidocaine with 1 in 100,000 adrenaline and 8.5% soda bicarb in a 10:1 ratio is prepared, and 10 ml is injected in the palm, 2 ml in the proximal phalangeal region, 2 ml in the middle phalangeal region, and 1 ml in the distal phalangeal region. The tendon repair can be done using this technique alone. The advantages of using this technique are the chance of fewer post-operative ruptures, since the intraoperative testing of the tendon repair can be done, and these repairs get less stenolysis because the surgeon is able to vent the pulleys that impede the full flexion or extension and can be seen on the table. Surgeons can educate the lucid patient during the surgery. It also guides the patient in the decision whether to do an FDS repair or resect the FDS slip while repairing the FDP, and seeing the full active flexion and extension with no gap during the surgery empowers the surgeon to start the post-operative protocol. And of course, reiteration of the surgical basics: a good lighting, a good pneumatic tourniquet, a surgical loop for magnification of 2x to 4x, and good hemostasis. Armed with all this knowledge, we shall now go into the surgical details. The first step is adequate incisions. We need incisions at the skin level for exposure to retrieve and repair the tendons. This will be decided by whether we are going to do a proximal window repair or a distal window repair, and the position and orientation of the wound. We will also need to make incisions at the pulley level for exposure or venting. This will be decided by the level of the cut and keeping in mind the function to be achieved. As we have seen, the first decision to be taken is whether we are planning a proximal window repair or a distal window repair. After that, we shall deal with the extension techniques for the wound. This window repair concept was described by Graham Lister. When we flex the interphalangeal joints distal to the injury, if more than 0.5 cm of the tendon glides into the wound, we need to make a proximal incision only. If just about 0.5 cm of the tendon glides out, we need to make both a proximal and distal windows. If less than 0.5 cm of the tendon glides out, we need to make a distal window, or sometimes we may need to make combined windows. For example, in this patient, on flexing the interphalangeal joints, about 1 cm of the tendon glides out. This needs only a proximal window repair, and it is enough just to make a proximal incision. On the other hand, in this patient, on flexing the distal interphalangeal joint, there is less than 0.5 cm of the tendon gliding out. So this needs a distal window or a combined window repair. We need to make an incision both distally and proximally. As far as exploratory incisions are concerned, we can make Brunner's incisions, mid-lateral incisions. The extension of the wounds are for exposure and access. It is important to remember that the viability of the skin flaps are a priority and should be maintained. We shall see different orientations of the skin wound and how to extend them. If there is a transverse wound on the middle, the wound must first be extended up to the neutral line on either side, and then it runs along the mid-lateral line up to the next interphalangeal joint crease, and after that it goes like a Brunner incision as an oblique pattern, or it can be continued as a mid-lateral incision, which was advocated by Bunnell. If the wound is obliquely oriented, also the same principle of extending the wound up to the neutral line, then running along the neutral line till the nearest joint crease, and then forming the Brunner incision is done, as shown here. If the wound is at the neck of the proximal phalangeal region, most probably the proximal end has retracted up to the A1 pulley. The distal incision is made as has already been described, but proximally there is no need to make an incision on the proximal phalangeal region. An incision is made over the distal palmar crease to access the region just proximal to the A1 pulley, where the retracted end of the tendon can be found. If the wound is U-shaped or C-shaped, the distal incision will have to be made from the summit of the C or the U, as it may be, to the neutral line, and and then extended along the wound as a Brunner's incision. When making the proximal incision for exploration, we must remember not to extend along the shorter line where it may make the flap very long and non-viable. We can extend along the longer limb of the C or the U and then reach the interphalangeal joint crease. If the wound is at the level of the metacarpophalangeal joint crease on the volar aspect of the finger, the wound can be extended proximally taking into account the crease lines. Just skin incisions may not give exposure to the tendons as they will be within the sheath and the annular pulleys may be covering them. We need to make the correct incisions in the annular pulleys to expose the tendons and repair them. If the injury is at the level of the C1 pulley, we can vent the distal 1/3 of the A2 pulley. This will afford exposure to the tendon and also prevent the impingement of the suture line by the pulley. If the injury is at the level of the distal A2 pulley, we may have to vent the distal 2/3 of the A2 pulley. However, 1/3 will still be intact to provide the adequate biomechanical support. And if the injury is at the level of the middle of the A2 pulley, we can vent the proximal 2/3 of the A2 pulley and leave the distal 1/3 intact. The method of releasing the annular pulleys is also important. If it is open straight, it may be difficult to close. If we need to close, we can use what is known as the L technique or the Z technique. By the L technique, the annular pulley is opened in the form of an L-shaped incision to afford a funnel-shaped exposure of the tendon underneath. By the Z technique, an incision is made in the pulley in this fashion and the two flaps of the pulley are raised like this to provide adequate exposure of the tendon for repair. The two flaps can be replaced and sutured as shown. Once good exposure has been achieved, we need to see methods of tendon retrieval. First, we need to understand how tendon retraction occurs. Then, we shall see the techniques of retrieving the tendons and the technique of tendon arrest after retrieval. When the injury to the FDS and FDP occurs distal to the vinculum brevis of the superficialis and vinculum longus of the profundus, the retracted proximal end stays at the A2 pulley level because it is retained there by the attachment of the vinculum. On the other hand, when the injury to the FDS and FDP occurs proximal to the attachment of the vinculum brevis of the superficialis and vinculum longus of the profundus, the proximal ends of the FDS and FDP retract to the level of the palm at the A1 pulley level. Retrieval of the distal tendon edge is done by flexing the distal interphalangeal joint and, if necessarily, the proximal interphalangeal joint to bring the tendon edge into optimal position within the cruciate window. The retrieval of the proximal tendon edge is a little more difficult. Use of a skin hook. According to the technique described by Morris and Martin, a single pronged skin hook is carefully inserted into the sheath and one tendon edge secured and withdrawn. The second technique is use of the railroading catheter described by Sormelis and McGrauther. The catheter is introduced retrograde through the digital sheath, sutured to the proximal tendon and then brought out through to the site of injury. Other techniques like the careful use of a hemostat to grasp the cut end of the tendon and retrieve it, or milking the forearm can also be done, keeping in mind that further injury should not be caused to the cut end of the tendon. Once the tendon has been retrieved and brought to the site of repair, it should be arrested by using a hypodermic needle which is impaling through the annular pulleys and the tendon. To summarize, this shows the wound, the incisions and the exposure, the tendon retrieval and the tendon arrest after retrieval. Now it is ready for the repair. We shall deal with the repair under the three important topics of core suture, coaptation suture and sheath repair. The core suture is the main suture that brings and holds the tendon ends together, usually applied within the substance, that is the core of the tendon. There are usually three components to any core suture: the longitudinal component, the transverse component and the link component. The link component is a junction between the longitudinal component and the transverse component, or between two longitudinal components. Usually the longitudinal and transverse components are placed inside the tendon substance and the link component lies outside the tendon. The transverse and link components usually convert the longitudinal pull of the suture to a transverse compressive force, and the function of the longitudinal component is that it allows placement of the transverse or link components away from the divided end of the tendon. The transverse component can lie either distal or proximal to the end of the longitudinal component. Similarly, the transverse component can be placed in the form of an arc, otherwise called the grasping loop, or in the form of a loop when it is called a locking loop, or in the form of a knot when it is a knotted suture. So all the major types of techniques of core suturing can be classified according to the criteria we have seen so far. Now we shall go into the different factors that go into the different types of techniques of core sutures. These factors depend on the suture material, the caliber of the suture material, the plane of repair, the loop configuration, knot location, number of strands crossing the suture line, the suture purchase in the tendon, and the gap formation. The ideal suture material for flexor tendon repair needs to be easy to use. It should prevent gap formation but at the same time maintain its tensile properties until repair has achieved enough strength. As far as the suture material is concerned, each suture material has its own advantages and disadvantages. Silk as a suture material has a very high local reaction. Stainless steel is very strong but it is very difficult to handle. Polyamide or nylon is very difficult to handle again, but there is very limited reaction. Ethibond, which is braided polyester, has a mild reaction and it is easy to handle. Polypropylene, on the other hand, also has a very limited reaction, but it is difficult to handle. So to summarize, non-absorbable synthetic sutures like monofilament nylon, monofilament polypropylene are used in repair. Higher tensile strength and stiffness is seen with coated braided polyester rather than monofilament nylon and polypropylene. As far as the caliber of the suture material is concerned, 4-0 material is weaker, but 3-0 material, though marginally stronger and increases the material strength, it does not improve the strength of repair. When we need to decide the plane in which the repair is going to be done, we can remember that the blood supply is mainly in the dorsal part. Diffusion is felt to be the primary source of nutrition during healing, and biomechanical advantage and increased tensile strength during finger flexion are achieved with dorsal sutures. There is an increased work of flexion with volar sutures, hence dorsal sutures are more preferred. As far as the loop configuration is concerned, the locking loops are stronger and provide greater gap resistance in two-stranded repairs. Studies have proved that the locking loops are better than the grasping loops in flexor tendon repair, but the advantage disappears with 3-0 or heavier core sutures, as the holding capacity of the suture grips of the tendon healing is then impaired. Though the strength increases with the increasing number of core sutures, the gliding resistance also increases. When applying a suture to repair a tendon, there must be a knot. If the knot is located inside the substance of the tendon, it may interfere with the healing at the repair site. If it is outside the substance of the tendon, it may interfere with tendon gliding, and significant increase in tensile strength at 6 weeks has been noted with the knots inside technique. These points have also been proved with adequate studies. The strength of the core suture is proportional to the number of strands, and 6 and 8 strand repairs are the strongest, but increasing the number of strands increases the bulk and resistance to glide. It increases the tendon handling and adhesion formation, and it needs more tendon handling as we need to pass the needle through many times, which could lead to uneven loading of the tendon. The next point to be considered is the amount of tendon that is going to be involved in the repair. Purchase greater than 1 cm and less than 0.4 cm causes weaker repairs. Repairs with more than 1 cm core suture purchase failed by suture breakage, whereas repairs with less than 0.4 cm purchase failed predominantly by suture pullout. So the transverse component of the core suture must not be less than 0.4 cm, as it will result in a poor repair strength. It must not be more than 1 cm because it gives the same strength as a 1 cm purchase but adds to the bulk due to the accordion effect, and 1 centimeter length gives good repair strength. Hence, 1 centimeter purchase is ideal when taking a bite in the proximal and distal tendons. The last criteria is the gapping that occurs at the tendon repair site. This is usually followed by increased adhesion formation. It has been shown that gapping more than 3 mm correlated with decreased tensile strength and rupture, and gapping more than 2 mm correlated with poorer clinical results. So the choice of suture and suturing technique must ensure that the gap that remains is less than 2 mm. The commonest used technique is the modified Kessler-Mason technique. This is a two-strand repair. Summarizing, we see that the strength of the repair is proportional to the number of strands. The locking loops increase strength but may collapse and lead to gapping. Knots should be inside the repair site. Increased suture caliber increases the strength but also increases the volume of the repair. Monofilament 3-0 or 4-0, probably best suture material would be Ethibond or polypropylene, and dorsally placed sutures are stronger. And the two-strand modified Kessler-Mason suture is ideal for immobilization protocol. If early active protocol is started, minimum of 4-strand suture technique is needed. The next important suture or the coaptation sutures were circumferential epitendinous sutures used to make the repair more tidy. They grasp not only the epitenon but also the tendon substance, so they are also called peripheral sutures. The strength of the peripheral suture has been found to be increased by increasing the suture purchase from 1 mm to 2 or 3 mm, increasing the number of suture passes and deeper suture grasps. There are different types of coaptation sutures starting from the simple running stitch to running lock loop stitch, Halstead continuous horizontal mattress suture, the silver-squared cross stitch technique, and the horizontal mattress intrafiber technique. The most commonly performed is the simple running stitch using 5-0 or 6-0 polypropylene. The advantages of the coaptation suture are that they improve the tendon glide by reducing the cross-sectional area. They add to the tensile strength, almost about 20% is added. They have been shown to improve the gap resistance and the force of the repair by about 10 to 50%, and they also resist gap formation, which is the first step that occurs in repair failure. The coaptation suture can be done after completion of the core suture or can be applied first but tied after completion of the core suture. This can be done by applying the posterior part of the epitendinous suture first, then completing the core suture, and then completing the epitendinous suture by applying the anterior part. Applying just the core suture and the coaptation suture is not enough. If the pulley is not repaired, it may lead to bowstringing, causing a biomechanical disadvantage, and the poor excursion that results translates into less joint motion, and adhesions and rupture at the remaining pulleys can occur due to increased stress at those levels. Apart from the biomechanical advantages, pulley repair also prevents extrinsic adhesion formation and helps rapid return of synovial nutrition. However, it may be a little more technically difficult and it causes increased foreign material at the repair site, and most importantly, it may narrow the sheath and restrict the glide of the tendon. To avoid constriction by the pulleys at the zone of repair, the pulleys can be vented, or the segment of the pulley can be excised, or the L-shaped incision of Lister or the Z-shaped incision, as has already been discussed, can be done, or the reconstruction can be done with the tendon graft or extensor retinaculum to avoid tight closure. Newer techniques in flexor tendon repair, like the use of the Merceline mesh sleeve attached with the cross-stitch peripheral sutures, or the Dacron splint, or the internal stainless steel anchor, have been tried but not yet popular. This picture shows the Tenofix device, which is implanted into both the proximal and distal ends of the tendon a few centimeters away from the cut end, and then approximated using an obturator. I hope you liked the video. Click on the following links to see more about the basics of flexor tendon injury management, like the anatomy, the tendon healing, the biomechanics of the flexor tendons, and more. And do not forget to subscribe to keep connected with the latest in learning hand surgery.